as therapists and as clinicians, I am concerned about the problems that are pertinent to the person's functioning, that are pertinent to their engagement, that are pertinent to their motivation, and that are pertinent to the risk that would make them functionally deteriorate. Hello, welcome and kumusta. Thank you for joining me. This is How Your Occupational Therapist, and welcome to OT Conversations. In this episode, we will talk about this phrase called, so what? Yeah, so what? And then what? So what and then what? This is a thing that's been going on in my head most of the time. Every time I am having some kind of an MDT meeting, and if I have some conversation with other colleagues or I ask them what's been happening, so what? Let this phrase be your guide when you are planning your intervention. What do I mean by that? Like, for example, say you're working in a critical care facility and you go and ask them what's been happening. And then they say, oh, the person has had some lung surgery and there has been some heart problems and the blood pressure is a bit high. Well, that's good. And you have that MDT meeting and that'll be raised, that'll be discussed. Or a next procedure is planned for this person. Say they'll have a bronchoscopy, for example, or they'll have an ultrasound, or they'll have x-rays. Yes, we know that. We know that this is the current medical plan. But then for me as an occupational therapist, the question is, so what? And then what? What are we going to do about this? What are the problems? For example, the patient is on special medications that enables a person's heart to pump at the right pressure, for example. They're on ionotropes. Yeah, they're on ionotropes. And then what? What are the problems? At the end of the day, as therapists and as clinicians, I am concerned about the problems that are pertinent to the person's functioning, that are pertinent to their engagement, that are pertinent to their motivation, and that are pertinent to the risk that would make them functionally deteriorate. So I'd be paying attention to these concerns. So if I hear about a person still on antibiotics, so what? Isn't it? They're on antibiotics. What does that mean? It meant that they are controlling the biochemistry or whatever infection that they have to kill whatever bacteria that is moving around the system. So that is what they're doing. So what? What are the concerns? As an occupational therapist, so they're on antibiotics. Well, what if this antibiotics is sorted out? This will be sorted out in a few days. Once that antibiotics has been sorted out, and then what? Can they go home? Are they going to be safe to go home? These are the ones that's going on in my head. Always the question of, so what? Sometimes you have some MDT meetings, say in a neurology ward. Everybody's going to be looking at the MRI and the CT scans and look at the brain and the status of the brain. Okay? Again, the question comes back to me. So what? Okay? You can see that there is PAX or partial anterior circulation stroke. So what? So what if there is? For me, the question is, what are the problems Because I don't have to look at that brain at the moment to know what the physical problems are. You can assess the physical problems by doing your neurological examination. And then once you know what the problems are, the next things are, what are the functional problems that this is giving to the person? And then once you know what the functional problems are, then what? Then you're going to try and address it. Okay? Knowing the state of the brain at the moment is good to know, but then what? Is there any medication? Can you give a person any medication to address what was already damaged in the brain? Of course not. You won't. You can't. The damage has already been done. The problems is on the upper limb, the postural control, the movement. And when there is a problem on the upper limb, so what? So what if I know what's the state of the brain? Because there's no medication that you can give that will address the upper limb movement again. What you can do is you can start moving that upper limb again, stimulate it, wait for the effects of the penumbra to come down, the swelling of the brain, okay, to come down, those learned non-use, wait for the swelling to come down, but you need to stimulate, you need to move. That's what, yeah, okay, so that's what you need to do. And after that, say you move the hands and you did the therapy. So what is the next question again? So what if I move it? They can't use it anymore. So what? Yes, they can't use it, and therefore, what are the other problems? Again, as an occupational therapist, you look at the problems with their ADLs. Can they put on their shirt? Yeah. If not, then you'll have to practice. How are you going to do that? Do some modify interventions. The rate of restoration on the physical impairment is very slow, and it's very hard to bank on that, especially if the brain has been damaged already. It's very difficult, but there are things that you can do to prevent the joints from seizing. You want to maintain the soft tissue length of the hands and the intrinsic muscles of the hands. So you do your splinting. That's it. Preventative interventions. After you've done that, you carry on. Do some restorative interventions while you're in that part or while you're in the position to do so. If you're in an acute stroke rehab unit, for example. So carry on working on that. Do that. Yes, do the upper limb restorative, but don't forget that what you need to do is get the person to do their personal care. Brushing their teeth, putting on their clothes, moving from bed to chair, standing safely, walking to the toilet, wiping their bottom, putting on their top half, putting on their bottom half, putting on their socks, putting on their shoes, walking. If they cannot walk, use a frame. If they cannot use a frame because the one side is hemiplegic, can they use a tripod pad stick? Yeah. All you need to do is a partial weight bearing if the appropriate leg can weight bear. Even if there's tonal issue, you can still mobilize. The distance is going to be a problem. And then what? You need to get a wheelchair. Okay? If it is difficult to control and maneuver the wheelchair with both hands, use a one-hand wheelchair. Get one of those that can be propelled by one hand. If it's still difficult, use a power chair. If the chair is not suitable because you don't know what the state of the home is, do an access visit. Make some recommendations. Life does not end and it does not stop. We carry on doing. Okay? If you miss the washing and dressing in the morning, simulate it any part of the day. You know, just get a gown and practice doing the donning and doffing the sleeves. Do that. Yeah. So that's one of those techniques that you can do. And then obviously you can stimulate the mind in any way throughout the day as well. You don't have to have just one particular session. All right. Okay, so what is always good to ask. Okay, I'm not saying that you should be arrogant, or be disrespectful of your MDT mates. Yeah, but these are some of the guiding questions. There will be some problems, they will be forced investigations. The next question is, so what? Yeah, what are the implications on the functional side of things? What can you do to improve things? And if you can do something about it, restore it, modify the intervention, or support the intervention. Remember, RAMPs: restore, alter, modify, prevent, and support. All of these types of intervention. Then, if you can do these things, so what? Is the next question. Then you do it onto another case. You do it onto another case. You do it onto another case. Yeah, do it over and over and over again. This will build up your skill as a therapist. This is your job as an occupational therapist. This is your job as a therapist to help people. Okay? That's why, because you're a therapist. You're there to help. We are there to help. Okay? There will be problems, but we're there to help. One patient at a time. And in a day, technically, if you're giving 45 minutes of session day in, day out, wow, in an 8-hour job, you can see 8 patients. Is that impossible? I don't think it is, guys. Okay, I hope you learned a little something today. Just remember, guys, anything you do matters and has an outcome. Let so what be a guiding question every time you come across with complex medical terminologies. You will come across, especially if you're a younger clinician and you're not overly familiar with medical terms, the question will always be, so what? Okay? And then what? So what and then what? They have whatever procedure they need to do. Okay? Say, for example, look at this, they have mesothelioma. It's like, whoa, that's big, right? You don't know. It sounds like it's a specialist thing. Mesothelioma, right? So what? What does it involve? Mesothelioma, these are cells that are growing in the mesothelium, meso, in between the linings of whatever it is that's covering the lungs, sometimes in the scrotum. So what? Do they have breathing difficulties? If they have breathing difficulties, then what? What are the problems? Because as therapist, you will not be addressing the mesothelioma. You will be addressing the problems. Is the problem that of a physical problem, functional problem, cognitive problem, emotional problems? It's getting on and on. We're all getting wound up now. Like I said, anything you do matters and has an outcome. Until next time, guys. Bye. If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.